Hi, my name is Marie Romagnano, founder of Healthcare Professionals for Divine Mercy. I'm happy to present to you our educational conferences that integrate medicine, bioethics, and the spirituality of Divine Mercy in patient care for healthcare professionals. Because of their importance, even if you're not a medical professional, we invite you to join us. Today, I wish to introduce and offer a summary of a presentation given by Sophia Romagnano-Culbertson entitled Transitioning of Goals in the Pediatric ICU, Facing Life and Death. Sophia Romagnano-Culbertson is a registered nurse from the Pediatric ICU at the Children's Hospital of Orange County, California, also known as CHOC. Sophia presents a pediatric case study about a teen whom she named Supergirl. She died from a cardiac arrest and brain herniation due to an allergic reaction to peanuts. In her presentation, Sophia reviewed the current official neurological criteria for brain death. She also offered insights on the importance of incorporating early child life and palliative care teams, pastoral care, and other specialized form of care to assist both the patient and the family. In particular, the siblings need to be included as they are deeply affected by their loved one's terminal condition and they need to say their goodbye. Sophia touched upon other concerns related to the pediatric ICU. She pointed out that the healthcare professional has to be aware of the developmental age of the patient, as even young children are aware that their illness may be serious. It is important not to lie to them, but to be truthful and honest. During interaction with the family, the power of words can have an intense impact. So it is important to avoid phrases like, "You're young, you can always have another child," or catchphrases such as, "Time heals all things," as they really do not help in these situations. She offers examples that are more helpful and are more positive in their effect on the family. I invite you to listen to the complete presentation on transitioning of goals in the pediatric ICU, Facing Life and Death, by Sophia Romagnano-Culbertson, who covers this important topic for healthcare professionals and families. Thank you.
My name is Sophia, and I'm came all the way from California, like she said, and just going to be talking about some of the resources that I'm lucky enough to have at CHOC when I'm dealing with end of life with my patients. So, just a little bit about CHOC. Sorry, I figured out which button it is. There we go. Oh, nope, now it's going. Okay, sorry, figured it out. Thank you. So we're located in Southern California. In Orange County, and we started off as a little floor at the main hospital, St. Joe's, which has now grown to its own massive facility with a pediatric intensive care unit, a cardiovascular ICU, neonatal intensive care, our own oncology unit, medical, surgical, ER, you name it. So we've come quite a long way. We are also magnet recognized, and within my unit itself, we are a beacon recognized unit, which means we have the resources and nurse involvement within the unit that we become certified within intensive care, and we work to have better outcomes for our patients. Now, a lot of people ask why someone so young gets so into end of life, especially dealing with children. It's very difficult. It's a very hard place to be for a lot of families. For a lot of us that work in healthcare, we have patients that leave a mark on us and change the way that we might think about something. I refer to her as Supergirl for HIPAA reasons, as we all know. And it was very young in my RN residency, and she results of cardiac arrest from a peanut allergy, unfortunately herniated, and thus was pronounced death by neurological criteria. But the positive thing from this was she was able to donate almost every single organ in her body to somebody else and benefit somebody else. But outside of that, at the bedside, I was able to learn and recognize and see what a difference here at the bedside between doctors, nurses, pastors, priests, whoever is there, that we can do for the family. So in pediatrics, we're not necessarily talking directly to the patient, so we did that by supporting the family. So we braided her hair. Her favorite color was purple. We put purple bows in her hair. She had a Supergirl cape on, where that Supergirl comes from. And I'll never forget her family coming down to the OR to say goodbye to her and taking that cape off of her as she went on to help others. And the best part was is her heart actually went to another 13-year-old girl. So to this day, it still makes me a little teary-eyed. So even with the littlest things, we can make a big difference. So like many of other speakers have talked about today, it's really important to start talking about what we can do for our families right as a patient is starting to decompensate or a catastrophic injury. It's important to be compassionate and empathetic to these families, be aware of the cultural and religious spiritual beliefs for these families. So incorporating in your priest and pastor early on can make a big difference in the overall holistic approach to their patient. And another big factor is, especially in pediatrics, is be aware of the developmental age of your child. Children are not silly, they're not stupid, they know when something's going on. They are aware of their own issues, of their own sickness, especially my best friend works in oncology and she sees it time and time again. The patients know. Be honest with them. Be appropriate, talk at their developmental level. Don't lie to them, it's not going to help the child if they are awake. Unfortunately, in the ICU, most of my patients at that point are not able to talk to me. And integrate your palliative care team as possible. And that includes pain management, our ICU team, the subspecialties, child life here in the pediatrics, and so many other subspecialties to involve the family in making sure that they know everything and are fully aware of everything is going on with their child. And along with that, which I think is a little bit different adults, when you're discussing whether to withdraw care, is what was the family's dream for that child's life? So for one patient in particular of mine, he was a chronic cerebral palsy child, trach and ventilator dependent, and he got sicker and sicker as time moved on as he got older. And the reality was that mom, at one point, he was healthy enough she could take him to the park, even with his wheelchair and ventilator. He was able to do active things, and he would respond in his own way, as we find in the pediatric world. And over time, as he decompensated, that started to change. And her vision of what her child's life looked like changed. So she decided that the best thing she could do to support her child was to end his life peacefully and respectfully. And it was one of the first withdrawals of care I ever did as a new grad. And it was one of the most peaceful, wonderful experiences, and that's, as a result, is what I would hope that for children and adults, what they get to experience as their loved one passes on. Now, something that's really important in these situations, your brain sometimes goes to mush. You can't remember what's going on. You feel sometimes powerless, but your words can mean a lot to these families. And some of these might seem really simple or really, silly, but like I said, your brain's not all there. How are you feeling? The patient doesn't feel great. As a result, think of words of how can I best support you right now in this moment. I understand how you feel. Unless you've lost a child, you're never going to be able to connect to this family in that same way. I can only imagine how you're feeling right now, and especially I get this question a lot, and as a pediatric nurse, do you have kids of your own? So be aware of what you're saying in the delivery, because you mean well. You have other people to live for, also can be very misconstrued. And a better way to go about it is, how can you get friends or family at the bedside to support you and help you? And just some more phrases. And one sounds very simple and very dangerous to begin with, but I've seen it being said. You are young, you can always have another child. Obviously never a good statement, but their child was special. Encourage them to share memories and remember what that was special about their child. There's a reason for everything. Instead of doing that, what role does faith play in your life? And that's a great way to bring in your priest and your pastor, or rabbi, etc., to start having these conversations early on and also at the time of death. And a famous one that we're all probably guilty of saying of time heals all wounds. And it doesn't negate the fact that their child is still not going to be there. And I follow a lot of families of oncology patients that I've had the pleasure of taking care of for it after they pass on. And believe me, these families don't forget, it's not going to help them. And also, sometimes there's just nothing good to say. So being aware of your posture when you're speaking to these families, looking closed off is not going to help them go through this on their own. I've sat on the floor with families and cried with them, and I've prayed with them. Be at their level, be interactive with them. Eye contact can sometimes be a sketchy topic depending on the culture, so be aware of your culture. Direct eye contact is sometimes not a part of that particular culture. And children don't always look you in the eye if you have siblings, so be aware they're listening. They're there in the room with the family as well. Facial expressions as well. Be aware what your face looks like. I know we work really hard as healthcare professionals to have that, stone face, but, smile. They're searching for positive emotions at this time, as hard as everything is. And the last thing, touch. Be aware of your cultural considerations and family norms, and always ask the family. I had a situation where I had a sibling come up to me. He's just standing there, and he was looking at me like, I need something from you. And I asked him, like, would you like a hug? And he nodded his head, and he's hugged me, of course. But just be aware of what your family needs. Sometimes that's not something they would want either. So comfort care specifically at CHOC, what I'm lucky enough to have resource-wise. So we have a comfort and palliative care cart that I actually started with another person in another unit. And it has different books, notepads, bows, because it's pediatrics, so we got to make them look cute despite our best efforts. And different resources for the family for comfort and things like that. We also have a bereavement cart, so if we have a patient that passes and we don't have our child life or social work team there, we're able to put together last minute things like handprints and do different memory making tools last minute as well. And if they're also during the day as well, and we can get it at night as well, we can get different family trays with nutrition so they can stay at the bedside and they don't need to go get food or feel like they need to leave. And something that's really special in working in pediatrics is child life. They are a wonderful resource within our hospital. We are able to make handprints of the child, locks of hair, make actual molds of their hands, and those are special memories that these families take with them. We do family trees with their handprints and all the prints of the siblings and write their names on it, and also supporting the siblings. The siblings they're there as well, and they know what's going on. We have a lot of books and resources that the child life will spend and bring them into the room, even if it can be a little bit of a catastrophic, injury, and it can be a little daunting at first, but getting them in there so they can say goodbye to their sibling. But another cool thing, which is one of my favorites, is if time allows, a recording of the actual heartbeat of the child. And one of my favorite memories in relation to that, we had a little girl who unfortunately was a result of a non-accidental trauma, and her favorite movie was Frozen. So unbeknownst to me at the time, I did my usual thing, bathed her, got her all cleaned up. Mom had brought a lot of her favorite dresses from home, so we got her all dressed up in her dresses, and one of her main injuries was on her actual head. So we're lucky enough we have the resources. I found a hat that actually looked like Elsa's hair. Not knowing that was the song Mom had chosen, so Mom came back from the shower and about cried in my arms. Not knowing that. So, little things like that can make a huge difference to your patients and families. And we also are lucky enough to get volunteer photographers for infants under a year. We have Lay Me Down to Sleep and other volunteers that can come in without, of course, violating HIPAA or anything like that. And then, of course, our chaplain and our resources to get their appropriate spiritual needs addressed at that time. And of course, being there in the final moments, it's the hardest, but sometimes the most beautiful moments for this family. They're able to say goodbye and be there at the bedside. I always say, we always are taught, never cry more than the family. If you feel like you need to remove yourself, it's okay to step out of the room. It's not easy. We always encourage our families, even when they're intubated, get in the bed with your child, or if we have a little baby, we'll get a bigger bed so mom can cuddle and love on the child. Same with dad and other family members. And, of course, once the child has passed, we do encourage the family, if you would like to be a part of the bath, if we can, bathe the child. It's very cathartic for a lot of families, and it's very healing. And also, we also have a lot of time where families want to stay with their child for a long time. We try and give them a warning. Your child is going to start to change in color and pallor, start to pool. Sometimes the best thing to do is kind of give them a heads up of what's going to happen, so they're not, as they're spending hours and hours with their child, they know what they're in for. So another topic within end of life is death by neurological criteria. It's the total and irreversible cessation of the entire brain, including the brain stem. The definition has not much changed since then. Within pediatrics, there are certain algorithms to diagnose brain death in infants and children. It varies slightly from adults based on their gestational age and over 36 days. Part A is our physiological parameters have normalized, so we're normothermic, we're normotensive for the age. A coma has been identified. Examination reveals absent brainstem reflexes and apnea, which brings us to the actual exam part. It's a lot of different factors that come together, and as sad as it is, I find when we are dealing with children in these states, it's a lot easier for the family to digest what the end of life of their child's going to look like, because they don't feel like they have to make that decision for themselves. They're not stuck. And then, of course, we have the documentation of the exam. My hospital is something very similar to this, and it just goes through every single aspect of the brain death exam. The most important part of the brain death exam is your apnea test. It's required that if they have a breath, when their CO2 goes above 60, they have failed that part of the exam. And along with other parts of the test too, if there is some sort of trauma and they cannot do what's called the Doll-Eye test. There are other things that can be done, like cerebral brain flow studies and EEGs as well. When providing care following your brain death, the state of California, the legal time of death is completion of the second exam. But something that can be very confusing to families is that the withdrawal of the ventilator is not always immediate. We can allow the families to have more time, get the family members there if necessary. And it's important as the nurse at the bedside to continue that standard of care. But something to also keep aware of, because the child still looks alive on the ventilator, to not refer to them by name anymore. It does help the family continue to process what's been going on. And also, if the family wants to, and when it's not something we discuss with them at this time, refer the case to organ procurement. So in Southern California and area, One Legacy is our organ procurement agency. Within 1 hour of death, it is important that you call, and we're able to see if they are a candidate. If you have a patient within our organization in relation to One Legacy that has a catastrophic injury, we are advised to call them and get them in the system sooner, so they're able to come in and look at the chart and see if they'd even be a candidate. Because per hospital guidelines, it's important that we don't mention donation directly to families. It can be a conflict of interest, and sadly, they may not be eligible, which can give family a lot of hope in these injuries, and it may not be appropriate. 76% of hospital mentions of donation resulted in a family decline. So be aware, just keep on doing what you're doing at the bedside, and let whatever organ procurement team you have come in and have that conversation with them. They're trained to have these conversations with them, and they're much more prepared. Oops, sorry. So one of the things that we do is we do our best to honor their family's gift. Something we do when we have a One Legacy patient, and you might have seen it go viral in the news. We call all the units, and we have them go line up in the hallway that goes to our OR, and we have the family, when they're rolling the patient to the OR, walk through that with all of the staff honoring their families. We also, right after that, we take the family outside the hospital. We have a special flagpole that we raise the One Legacy flag, and along with that, the family takes home a flag as well. And something you might not know specifically about the Rose Parade float, you probably see it every year. It's the Donate Life float, and it's always wonderful and beautiful and honors all these the recipients and the families' gifts and everything. But each rose, actually on the vial that goes into the float, has a patient's name on it. And these patients have the option to do that every year, which is wonderful as well. And there's also the Donate Life Run Walk in Southern California as well, which my unit participated in and we got to be a part of, which is really wonderful as well. And then just final resources as the family is leaving. Our hospital also sends bereavement cards to the family on important dates. We do financially, if we can, help them with mortuary and funeral arrangements. A lot of our families are low income, and this is a very surprise for a lot of families. It's not something they were expecting. We do offer grief counseling for parents and siblings, and we do offer faith-based grief support groups as well. Well, thank you very much, and I appreciate your time.
Thank you for viewing our program. Please see our website, divinemercymatters.org, for additional educational resources. Thank you.